The dates on the board here all symbolize something. To some of us, they may symbolize more than others, but July of 2018 is when our journey really started with accreditation. My predecessor came before you and asked for permission to start the process, to actually apply to the FAB board to begin work on accreditation. And for some of us at the health department, we probably were kind of scratching our heads saying, oh, are we really gonna do this? Accreditation had been talked about several times before at the health department, but had never really come to fruition. But this time was really different. This time there was a plan, there were action steps, identified leaders, and so the work began. We divided into 12 domain teams at that time and involved multiple staff members and started looking through what was going to be required for each of those domains, the documents that were required to collect, the criteria that those documents had to meet, the time frames that they had to meet, and it was no small undertaking. So June 26th of 2019 is when we finally had all of those documents collected. There was a ceremony. We had it at an all-staff meeting. Some of us will remember, and we actually pushed the submit button for FAB to officially apply. We submitted 391 documents to them. So again, huge amount of information and things collected along the way. It wouldn't be until February 19th and 20th of the next year that we had our on-site visit from FAB. That FAB visit involved the team from FAB meeting with our domain leaders, meeting with various staff members, meeting with community members, elected officials. It was a 2-day visit. We had our state health department there. And when they left, everyone had a pretty good sense. We felt like the visit had gone well. Little did we know that a pandemic would start the following month and a wait would begin yet again. So we actually did not learn of a decision that they had made due to the pandemic until that following fall. September 4th, to be exact, was when we received notice that they had deferred our decision and that they were requiring some additional documentation from us. We had, at that time, 1 year to supply the required documentation. During that time, though, most of our staff was still heavily involved in the pandemic response, and we did end up having to ask for an extension on that. So February 28th of this year is when we were able to finally compile all of the documents and resubmit again, and then the wait began yet again. They only meet once a quarter, and when they had received our documents, unfortunately, we did not get on the board meeting until August 18th of this year. We would not know until several days later that we had actually been accredited, but August 18th, the committee did meet, and the decision to confer accreditation upon us was decided. Of course, since then, we have had celebrations and been able to share that publicly. So a little bit about accreditation. I've shared our journey, which was certainly an interesting journey going through this during the pandemic also, but FAB is what we affectionately call the Public Health Accreditation Board. They are the sole national entity that accredits local, state, tribal, Army, and territorial health departments. So they're the only one here in the nation that does that. Accreditation really provides a framework for health departments to identify performance improvement opportunities, demonstrate our credibility, develop leadership, and improve relationships within the community. This was a way for us to engage all of our staff across the board, not just our leadership team and supervisors, in transformation and improvement efforts, and that will continue throughout as we begin our work on reaccreditation also. Accreditation really is a vehicle for transparency and trust in public health. We certainly, those of us in public health have been on a roller coaster over the last 2 years, but we want our community to feel confident that we have met these national standards for performance and quality, and the services that we're receiving are as such. We were accredited under the version 1.5 standards and measures, and they are getting ready to roll out 2.0. So we will get to learn more about what 2.0 means. I do know there's less domains and less documents, but we'll get to learn all about that as we work on our reaccreditation. So what are our next steps? Well, as I said, we have enjoyed the past few months of just celebrating this win and being accredited, but the work really has started. So we're required to do an annual update. For our health department, that will be every September. That report is due based on the quarter in which you were accredited. So the annual report has to include several things. It has to include if we have any significant changes in our health department that would affect our ability to conform with standards and measures. We do have to touch upon any measures that were either not demonstrated or slightly demonstrated, in which we do have a small list of those. And then it really looks to the staff to share stories and reflections and highlights of our accreditation story from across the health department. So it'll be another great way to introduce our staff that haven't been involved with it. Reaccreditation is every 5 years, so we will likely really be starting on that process soon to learn what those steps involve. Reaccreditation is important so that we continue to evolve and improve our public health practice to serve our community, and though it's not just a one-time accreditation effort. So the seal you see up here is a seal that we're very proud of. You'll start seeing the seal on more of our documents that come forward. We are one of only 7 health departments, local health departments here in the state of Kansas to achieve this. And so this was, again, a labor of love for many of us that have been involved with this. It was literally 4 years in the making. And so we're excited about the work that we've done, and we look forward to continuing to improve our efforts to best serve our community. I'm going to take time for questions as we go through. We have such a different topics today that we thought we'll just take questions as we go through. Are there specific questions about accreditation that I could answer?
Questions?
Let's start with, are there any costs to the taxpayers for being an accredited agency?
So there is cost to becoming an accredited health department. So far we've been able to use grant funding, and so we will attempt to continue to do that. There is an annual cost every year to stay accredited health department. It's based on the size of your community. And so at this point we have not used tax dollars. We've been able to use grant funding, and that would be what we would continue to pursue.
By being an accredited agency, does this open you up to grants or opportunities for programs that you wouldn't have been able to otherwise?
We believe that it will. We have not had a true opportunity to dive into that. You are looking at my grant writers really in the audience here. So we think this will open some additional doors. And I'm one that I like to learn from other health departments. And so I think that's a question that I'll definitely be reaching out to the other entities in the state to find out if that has opened some other doors and avenues that we might want to explore ourselves.
It took us quite a while to be able to open up our clinic that we did our ribbon cutting for maternal, child, and looking at that, all that offers, and we did that here this last spring. By being an accredited agency, are there programs that are going to come out of that go along with the accreditation?
Well, with our family planning program, we were able, that's through a Title X program, and so I don't necessarily think that those two tie together, but obviously just in general as a health department, looking at making sure we're doing quality improvement throughout, which would include that program.
Okay.
Further questions? All right.
All right, thank you.
Thank you.
I'm going to turn it over. Our next item is our mosquito surveillance end of year update with our epidemiologist Brittany Blattner and Craig Barnes.
Morning.
Morning.
I'm Brittany Blattner, the epidemiologist at the health department, and I'm going to review the data we've received for this year's mosquito surveillance season.
Now, Brittany, before you begin, Counselor Crowell just said he hopes they're all dead because it's cold.
Dormant, how about that?
Dormant.
All right, we set out traps at 5 locations you can see here. There's Elmont, Silver Lake, Wakarusa, Alameda, which is near Shearwood Lake, and Sumner, which is near Lake Shawnee. So we're taking into account both range of location and proximity to bodies of water in determining our trap placement. Here's a chart of the number of mosquitoes trapped at each location this year. Silver Lake clearly has the highest numbers, but there's been a large improvement in the numbers due to a change in mitigation efforts that Craig will describe to you later. Here is the chart we update on the health department website weekly throughout mosquito season. It compares the 2022 season with 2019 to 2021. You'll notice that we had much lower numbers of mosquitoes trapped this year, and speculations for the reason for that I will discuss soon to follow. These two charts show weather-related data. To the left, you can see that the number of mosquitoes trapped closely coincided with precipitation levels as expected. And of course, as temperatures declined, so did the mosquito population. So to give an analysis of the 2022 mosquito season, we only covered weeks 7 through 23 of the typical 24-week season due to funding limitations. The reason we saw lower numbers of mosquitoes this season is likely due to the effect of La Nina. They cause drought conditions in our area and therefore fewer opportunities for mosquitoes to breed. Now, it's important to note that drought conditions and lower numbers of mosquitoes do not necessarily mean that we are at decreased risk of West Nile virus. In fact, drought can increase the numbers. In conditions of drought, water sources are concentrated, and so are mosquito and bird populations. In addition, more people flock to these areas for recreational purposes, and that allows for more transmission of the disease. So this season, we trapped over 2,800 mosquitoes in 16 weeks, 47% of which were of the genus Culex, compared to over 5,900 last year in 24 weeks with 56% Culex. Our total mosquito count includes all types of mosquitoes, but we pay particular concern to the Culex genus because they're the spreaders of West Nile virus, filariasis, which includes heartworm disease in dogs, and encephalitis. I'm going to provide you with some West Nile virus data on both the state and county level. To the left, you'll see a chart of demographic data of West Nile virus in Kansas from 2015 to 2019. You can see that West Nile virus patients ranged in age from 5 to 89, but most were in their 50s. West Nile virus is asymptomatic in 80% of cases, so it often only becomes apparent in immune-compromised populations. However, when it does result in serious illness, it can be deadly. Across the board, neuro versus non-neuroinvasive disease tended to affect patients equally, but in those years, 50 to 74% of West Nile virus patients were hospitalized, and up to 14% died from the illness. The chart on the upper right compares Kansas and Shawnee County cases, deaths, and case rates from 2015 to 2022. As you can see, we've only had one death in Shawnee County during that time, but in 2016 to 2018, our case rate exceeded the state average. This was also during a period of drought, and it's important to note that areas east of Flint Hills have higher humidity and therefore have higher numbers of mosquitoes in general. We've had no reported cases of West Nile virus since 2018. However, there's a lag in reporting, so we may still see some cases in 2022. I'll now hand it over to Craig to discuss the efforts the health department has taken in controlling the mosquito population in Shawnee County.
Thanks, Brittany. So a lot of data there, right? So how do we use the data? And so one of the big things that we have been doing diligently over the last 6 years, we had a little bit of a break in there with COVID just because it, kind of hampered our abilities to do some of the control and some of the collaborative efforts that we are accustomed to. But if you will recall, and we'll talk about a little bit about the Dump Day campaign here in just a little bit, but what we've been doing, bless you, has been working diligently with community partners. And so one of the exciting things that was new for this year was an expanded relationship with Silver Lake. So as the updates that you've gotten from us in the past, you've seen that typically the Silver Lake trap is the one that traps the most mosquitoes. And that is in case really because of the layout, the geographic location, the lake, and when it fills up and things of that sort. So what we had is a great conversation with Silver Lake this year with their Public Works Department and their City Council to look at how they are currently spraying for mosquitoes. And then also starting to look here a little bit more at the use of granulars and mosquito ducks to provide an alternative way to lessen the amount of spraying that was happening and using these dunks in low-lying areas and where water would accumulate. So that is part of the effort that we did this year for mosquito control to hopefully limit the mosquitoes. Now, as Brittany talked about, we had a drought this year. So were the efforts that we put in place partially due to help with the reduction of mosquitoes? Potentially. So we'll continue to evaluate as we go this year. But one of the nice things is that when we look at working with Silver Lake is a cost savings to their community by reducing the amount of chemical that they're purchasing with their department's budgets and lessening the amount of spraying that they're doing in their community as well. So that is one of the big benefits that's been done with that. We've continued our great partnership with Shawnee County Parks and Recreation. We provide their department mosquito dunks on a regular basis that they can provide and put into their parks, around their trails, on the golf courses, around the lake, in those areas where there's low lying. We had gotten a lot of, I don't want to say complaints, but worries about some of the, when you're teeing off on the golf courses, people getting bit up on the tee boxes. We have heard a lot less from that over the years, and so I attribute that specifically to the proactive nature of our Parks and Recreation Department being out there, putting out these dunks. The great thing about the dunks is they last 30 days of water activation. So you could throw out a dunk there that'll treat 100 square feet of water. And if the water dries up and it's still there, that doesn't go away, but when it fills back up, it's already preactively in there killing off the mosquito larva that's coming to that location. So it's a great way to provide kind of a barrier to that regular mosquito nuisance. Another thing that we're doing collaborative is continuing to partner with our environmental health program. They are the entity that does the setting of the traps and the picking up of the mosquitoes as well on the following day. But they have a great partnership working out if they notice nuisances, working with homeowners to provide mosquito dunks and doing some of that education firsthand right there while they're out in our community in the unincorporated part of Shawnee County. So it's a great thing that our environmental health program is doing, both educationally and then providing a preventative measure to those homeowners as well. And then looking at low-lying areas just out in the community as well, in the ditches and things of that sort off county roads. If they identify any debris buildups, they've been out there knocking those down and then providing and putting out the mosquito dunks where there might be some water collecting and helping cut down those mosquito populations. So this has also just kind of helped, additionally to kind of what Brittany was talking about, just a further understanding, that educational component about West Nile virus and the risk of it. And so we talk about a drought and we talk about, lessening those areas where water is actually accumulating. But when you do actually finally have a rain and it collects in those areas, that's where everybody is flocking to. And so being able to provide that education to individuals to get out there and to put on bug spray, wear lightweight, but long sleeves, long pants when you're out actually mowing the yard and things of that sort, and then providing these mosquito dunks to the community. So the big thing that we've been doing is our Dump Day campaign. It's a public service announcement that we've been doing the last 4 years. And so I wanted to share with you guys here quickly just the 30-second spot of the PSA that goes out during the mosquito
Fridays
season.
are dump days. Dump the water, dump the possibility of getting mosquito-borne diseases. Mosquitoes need standing water to breed. Take action, protect yourself from mosquitoes, and reduce standing water. Can't dump the water? Use mosquito dunks to kill off larvae. Put screens on windows, fix your gutters so water runs freely, dispose of old tires, wear long shirts and pants, keep lawn clippings away from storm drains, and use repellent. Fridays are dump day, Shawnee County.
Dump the water.
Dump the mosquito.
So I'm sure you guys have probably seen that. Sorry that you have to hear my voice.
I really like the voiceover. It's my favorite part.
If you guys need anything, I'm available. So, but this is a great opportunity. We got to engage some of our staff that don't typically get an opportunity to be in front of the public. And so I know they appreciate it. I think this is the third iteration of those PSA announcements that we've done since we started the campaign. So we try to create that as an opportunity to get our staff involved. There's two versions. You saw one of our two versions. We have two 30-second spots and a 15-second spot that go out there. We share it regularly through our social media channels during mosquito season, just as another way to reinforce that. Get out on Fridays, dump your standing water, and then to use the mosquito dunks. And so to kind of further elaborate on the Dump Day campaign, this has been a great collaboration that we've had in our community. It started off with those PSA announcements, and then it's evolved from there. And so what we are doing is, as we purchase with some of the funding that we received from the Kansas Department of Health and Environment for this to get those mosquito dunks. And so we provide those free to the community. As you see here, we have over 10 different locations and community partners that provide those as a free service. You can go in there and pick them up. Each one comes in this little baggie that you have here that's branded with our health department logo, the Dump Day logo, links to our Facebook page, but then also has a page in there that provides a resource as to how to use the dunks. Because you don't have to use a dunk in its entirety. You can break them up so that you have smaller to use over time, and each quarter will treat about 25 square feet of surface area. And so it has that in it, and we have, as you see here, this year we provided 237 of those mosquito dunks to members of the public. That's an increase from 2021 when we gave out 71, and then 42 that we gave out in 2020. So we have seen an exponential increase of engagement from the community coming through not only our office, but our community partners that picked them up. Silver Lake, once we had those conversations this year and we provided these same dunks, people were flocking in to the City Hall to pick up those mosquito dunks from the Silver Lake City Hall office. So
So,
yeah.
Craig, is this I guess you're just going to get to where I was about to ask, so go ahead.
Well, see, I right
I
there,
see
we
the
got
next
it.
slide, so.
So I wanted to take an opportunity to really provide some acknowledgments. And first off, to the Kansas Department of Health and Environment, who's provided that funding over the years for us to be able to do this mosquito surveillance program. And we've taken that opportunity and collected data over the years to then move from that surveillance, right, collecting the data, into these more control efforts to provide that educational component and to provide a mechanism to control the mosquito population in our community. We're excited to see that continue and how that will fold out in the coming years, and hopefully we'll continue to see numbers like we saw this year that are a lot lower, all right? And then Jim won't be asking about all mosquitoes being dead at the end of the year. I'm sure he's actually probably got a standing water in his garage that's got a heater on it, so he's collecting those so he can use them on his enemies. But, so we'll continue to do that and hope that, that we'll continue to expand and look at other opportunities. We're one of 3 communities in the state of Kansas that has a mosquito surveillance program. Reno County and Sedgwick County are the other 2. And so we are continually working with them to evaluate what they're doing in their communities on mosquito control so that we can be innovative and creative to help control that mosquito population. Also, I want to give a special thanks to our environmental health program, specifically Gary Larson and Tim Simons, who are out there and have been setting those traps and have been picking up the traps. They do a great job with that. And then Joey Webb as well, who has been helping really do a lot of that educational component in our community and providing that information to homeowners in areas where they're noticing either debris pickups or debris buildups in the ditches alongside of the county roads, or also noticing different areas on properties and things of that sort, whether it's a kind of a swimming pool that has filled up, that is not being really used, and having those conversations with homeowners and then providing those dunks and education on the back end to help cut down the mosquito population. And then lastly, I mean, a really big thanks to Dr. Christopher Rogers. He is the entomologist with the Kansas Biological Survey. He is who we ship off our mosquitoes to. He is the one who counts all the mosquitoes, and then he identifies what the different species are, specifically locating, as like what Brittany said, that Culex species that is the major carrier for West Nile virus in our community. And so without him, I mean, we wouldn't be able to do anything that we're doing. He provides a data set to us on a weekly basis, and one of the great things now is he is in constant communication with Silver Lake as well, providing that data directly to them and their governing body, and working back and forth, providing technical assistance directly to Silver Lake on what they can do to evaluate for the next mosquito season and moving forward. Again, like I said, to hopefully provide cost savings to the community, and then hopefully to the residents, less spraying and less mosquitoes being found in the community. So. And then the last thing that I kind of wanted to touch on here before I open it for questions is a new opportunity for 2023. We're exploring the possibility of expanding our mosquito surveillance and also looking at tick surveillance as well. So there are some potential funding opportunities that are coming around. So we're going to be meeting with Dr. Rogers this winter and evaluating the possibility of that and what it'll look like, what additional kind of time that will take for our staff to be able to do that. Can it coincide directly with our mosquitoes? I learned something new when Brittany and I met with Dr. Rogers that ticks are not dormant in the wintertime. There's ticks that are live and active even in the snow. So Jim, watch out for those, all right? But so that was something even that I learned new this year. And so we're gonna be looking at that and see if that's a possibility for us this next year to expand again into more and more into the surveillance field, now that we have an epidemiologist on our staff. And I know our environmental health team loves doing this. And so it's just another opportunity for them to provide education in our community and a great service. So with that, questions? Did I answer where you were going, or?
Yeah, but I got a couple others.
Yeah.
So obviously it looks like the number of dunks that you gave out like tripled this year.
Mm-hmm.
Are you expecting that to continue going up? And if so, you know, what's the top end of the threshold? How much can you afford to give away with the money coming from the state of Kansas?
Yes, that's a great question, and really, I wish I had an answer. I don't know. You know, we've continued to provide this information. I think more people are familiar with the Dump Day campaign now than they were in 2020. 2020 and 2021 is kind of a weird year when we kind of really started pushing those out because of COVID-19 and everything. A little bit harder to get into places to pick up those mosquito dunks. So who's to say that this last year, that $270 271 that we gave out is maybe that's the top threshold. You know, that's truly the engagement that we'll see. We have been able to, we still got stores, mosquito dunks that we have at the health department, so we know we'll still be able to provide them the next couple of years for sure if we're still around that 271, and probably even into 2025 as well. So we'll constantly be evaluating that and what that impact could be on the grant funding that we receive, and look for alternative avenues to pursue through other grant funding.
Okay, so they don't expire, or you're not?
They do
like-
not, no.
Okay.
Yep, as long as you
Alright.
keep them in a nice, cool, dry spot.
And then you've also mentioned the locations that you have, that you do the testing at.
Mm-hmm.
Those have remained the same the whole time, or are you continuing to expand those into new areas of the county as well?
Yes, great question. So when we started off the surveillance program, we actually had 6 traps. We had one that was at the zoo. And so after some back and forth after those first 2 years, it wasn't really trapping anything. And so we decommissioned that trap, but the other 5 traps have all stayed in those exact same spots. And that was done specifically, Dr. Rogers worked, I believe, with Lee Allen and looked at some topography maps with GIS, and specifically we're looking at areas to where we could get the best identification and look at mosquito populations. So they're specifically spaced throughout our community to give us what we feel is the best representation of what the mosquito population in Shawnee County looks like. So if things change or anything of that sort happens, we have the ability, because we still have 1 additional trap, to add a 6th trap back into the rotation. But at this point in time, I think working with the 5 traps that we have is going to be what we're looking at, because it does give us that good representation of our community.
And I don't remember what all the map was, but did you guys have one along the Shunga Trail or anything like that?
Let's look at it here. Whoop. So I don't think we have one directly along the Shunga. I'm believing that would be this body of water running through here.
Mhm.
But that's something that we can definitely, because if you notice, they're pretty well dispersed. We don't, with that one that we had in Gage Park was our kind of more centrally located location. So that might be something to have a conversation with Dr. Rogers about. The biggest thing that we need to do when we look at this is we have to try to find an environment that would be kind of a little bit more off the beaten path. Because even with the one that was in the zoo, we were afraid that maybe it was being tampered with. And so if they are, then that kind of defeats the purpose. But that's a conversation we can have with Dr. Rogers, and then probably Tim and the rest of the Parks and Recreation team to see if there's something there, that might be able to provide a location close to Shunga that might not be an area where the public might see it readily.
Okay.
A good question.
An alternate location, I would think, would be in North Topeka, where the drainage is just north of the river.
Okay.
We have those drainage areas that go into the river along North Topeka between 24 and the river area.
Mm-hmm.
Because I know that they've really had issues in the past with mosquitoes along that area.
Okay. Yeah.
So I appreciate your information. I mean, oftentimes we just think of mosquitoes as being annoying and not as a health issue. And so thank you for bringing that to our attention and all that we do, and how this relates to public health and how we can be better with our public health.
Thank
Yeah.
you.
Appreciate it, Craig.
All right. Thank you so much.
Thank you.
Thank you.
All right. I'm going to turn it over, I believe, to Carrie and Dr. Locke, who are going to give you an update on monkeypox.
Good morning, Commissioners. Katie Dobbs, Clinical Services Division Manager with the Health Department, here with our Health Officer, Dr. Erin Locke. We are going to just give you a brief overview on monkeypox, kind of a look at the global outbreak and what's happening more locally, and then just hit on some information about vaccination and treatment.
The last time I was up here, I did not imagine the next time I'd be here, we'd be talking about something like monkeypox. But, so we'll try to keep it brief and hopefully a bit interesting. So monkeypox is caused by the monkeypox virus, which is related in the same family as smallpox, which we all know from our history. There are more. There's other viruses like cowpox and I think Alaska pox, but that's where this group comes from. Monkeypox is primarily spread through direct, like skin-to-skin contact, in any way that can occur, hugs or sexual contact and so on. It's a bit of a prolonged disease. So you can be infectious for several weeks, and you can be feeling symptoms for several weeks as well. The good news for us with monkeypox is that our outbreak, it's rarely fatal. In fact, it's been less fatal in this outbreak than we thought it might be based on the statistics of the endemic countries, which we'll get to in a bit. And we're fortunate, one of the things that makes monkeypox different than COVID is that it is not a brand new virus, first of all. It's endemic in Africa. But also, we already have treatments and vaccine available for smallpox that we were able to quickly shift for monkeypox. So a little bit of why the response to this has been different this year. Okay, so the symptoms here, I've already touched on this a bit, but you might be exposed, and then you could have up to 3 weeks of incubation where you have no idea that you actually have been infected. Typically, people will begin with their prodromal symptoms, the fever, the chills, the not feeling good, maybe they think they have a cold, and then the rash will develop. In this outbreak, that could be reversed. You might get the rash first, and then you get these other symptoms later, but these are the pretty typical symptoms. Of course, the pox, the rash, is what distinguishes it. That's why we call it monkeypox. And these pox, they can be quite painful or even itchy to the point of painful. And so that's something that symptomatically really needs to be treated for a lot of individuals. And the pictures here, not too pretty, but these are examples provided by the CDC of monkeypox in the current outbreak. Actually, before I talk about the current 2022 outbreak, I did think it might be interesting to talk about the last outbreak here in the United States, which was in 2003. And we actually did have cases here in Kansas. In that case, the current monkeypox is spread here by humans, but in 2003, monkeypox traveled here through animals. And it was, I have the country, it was Ghana. There were several types of animal species that were imported from Ghana into the United States, into Texas. And then some of those were moved to Illinois, where they came into close contact with prairie dogs. And then those prairie dogs were sold as pets, including to people in Kansas. And there were 47 cases in Kansas, Missouri, Illinois, and Indiana, I think, as a result. So you can see this zoonotic, this animal link, and it was through direct contact. So just sort of an interesting history. Here we are 20 years later, and we've had humans bringing it in. So we'll get to that now. I've already mentioned it's endemic in West and Central Africa. Endemic means it's there all the time at a low level. In May, that the virus traveled to Europe, and then from Europe to the United States. And so far, we have had about 80,000 cases around the world. I took a look at the map this morning. It's pretty much everywhere. Russia to Australia to Brazil, it's everywhere. However, the United States has had a big chunk of that. There have been 30,000 cases in the United States. Fortunately, only 11 deaths of those 30,000 individuals. We may have a slide here, but the peak is already past, fortunately. It peaked in August in the United States, and that was about the time that we saw our 2 probable cases. I can't remember now, I apologize. Yes, here it is, yes. Here's the map of the United States, where you can see where the cases have been heavily located. Texas, New York, and California have had the most cases, they have the most people. Kansas has had 36 cases, Shawnee County, 2 of them probable cases, not confirmed cases. Here's the slide. That's what I was talking about. August was when we peaked, and now we are in November, and you can see that the levels are quite low. And if I didn't stress this before, the risk of monkeypox now is very low. I am not, we are still monitoring it and watching for it. We still need to be thinking about it and testing for it, but just for the individual on the street, the risk is quite low. Okay, so then talking about who has been infected or impacted by monkeypox. I think the point I'd really like to stress is that anyone can be infected with monkeypox. It is just close contact. That's all it is, to transfer from one person to another. However, the current outbreak has really been focused on men who have sex with men, gay, bisexual men through sexual activity. And so the majority of cases have occurred in that community. And so you can see on the graph here, the blue is cisgender men, and then you can see the women is like the little bit of kind of orange yellow there. So you can see it's mostly men. And then this also takes a look at age. So just wanted to point out that the majority of cases have been age 25 to 40. So that's where, so men in that range. I've already made this point about anyone can be infected, and so your pets can too, actually. So one of the recommendations for someone who is infectious is to avoid close contact with your pet so you don't get them sick. When we take a look at cases by race or ethnicity, this graph is looking week by week. And so as you can see, the line furthest to the right is the most recent. White individuals are in blue, green are Hispanic or Latino individuals, and that kind of purple color are Black individuals. And as you take a look, you might think, okay, it's somewhat even between those groups, but we do have to remember that the white population is more the majority in the country, so it does appear to be impacting people of color at a slightly higher rate. Okay, so just a touch on, as Carrie said, a touch on the treatment and vaccines. So, because of smallpox, and smallpox being an issue of national security, there have already been vaccines developed against smallpox. There are two. There's Jynneos, and then there's another one with an interesting name called ACAM 2000. But we are actually using Jynneos. It's safer, it's newer. We would be in a tight spot if we had to use the ACAM 2000. Although we talked about that at the beginning of this outbreak, that it might be the case. So this vaccine is approved for both smallpox and monkeypox. Just like with the original COVID vaccines, you have to get 2 doses to be fully vaccinated, and they're a month apart. So who is being vaccinated right now? We've not been campaigning that everyone should be getting vaccinated. So there's a very specific group of individuals that we think about. First, we think about our men who are having sex with men. They're the individuals who are the most impacted. We would really recommend that they go ahead and get the pre-exposure prophylaxis. If they believe that they are at risk based on their behaviors, sexual behaviors and otherwise, then they can go ahead and be vaccinated with the Jynneos vaccine. The second group of people are for those who have been exposed. Let's say a family member has been diagnosed with monkeypox and you're in the house with them. There's going to be a high chance of contact with that individual or the fomites in the house. You know, they'll touch a surface and you'll touch it later. Those would be another group of people that we would recommend going ahead and being vaccinated to prevent symptoms developing. So Carrie provided the data that in Shawnee County, we have provided 60 total doses of the Jynneos vaccine to individuals, both pre-exposure and post-exposure. That vaccine was provided to us by the Kansas Department of Health and Environment, and we continue to offer that as indicated. Anything else to add on that?
I will note that Jynneos had typically been provided subcutaneously, so 1 vial equaled 1 dose. But in early August, about the time the health department was getting involved with this, Jynneos was authorized to provide intradermally, so we can give a much smaller dose, and that 1 vial would serve 5 people instead. So that really helped expand the availability of vaccine.
The difference between like kind of putting that vaccine in the fat kind of under your skin versus just directly under the top of your skin. So, but it's a difference in how much we can, how far could we stretch it? Because there was a very real concern that we were not going to have enough vaccine and that this could be a real problem in the United States. And so it's really nice to be here on the far side of it where we're feeling a lot more comfortable. So that's the vaccine, that's the prevention piece as far as what we can provide at the health department. When it comes to treatment, we do not have treatment that is specific for monkeypox. There is an antiviral that is authorized or approved for smallpox, tecovirimat, or TPOXX, which is much easier to say. Now, even though it is not approved for monkeypox, it is still being used and under like an investigational headline by the CDC. So this is only available for individuals who are really sick, like they're looking like they're could die from monkeypox, or they have it in places like their eye and they might lose their eyesight. So that would be the severe disease. Or if they're at high risk, individuals with HIV, cancer, on medications that make them immunocompromised, really young children, pregnant women, those would be the individuals. To my knowledge, it has not been utilized in Shawnee County. I think we would probably hear about it if that was the case. And so healthcare providers can identify it, they can start to use it, they just need to fill out paperwork and submit with the CDC for monitoring. And eventually I think it will be approved for monkeypox based on all the data that's currently being collected. That's it. We kept it short. So any questions about monkeypox?
Questions?
I don't.
No, I don't either. Except, who knew you could get a prairie dog as a pet?
Yeah. That's right.
Maybe why you shouldn't.
Yes, maybe why you shouldn't. Yeah.
Well, thank you very much.
Yep, you're
Thank you.
welcome.
Appreciate it.
Yeah.
Next up is Dr. Cooley, I believe. Welcome.
Good morning. I'm Dennis Cooley. I'm the chair of the Public Health Technical Advisory Board. It's been a while, so it's good to see you. And this is the first time I've been in this building. It's very nice. It's good to see that Jim gets to sit up front a little bit.
I know.
Used to sit out back.
He's got a real desk now, too.
Yeah. He's sitting at the big people table, not the kid table. So I'll be very brief. Just a little update on what's been going on with the Public Health Technical Advisory Board. As you remember, this came about from a resolution in 2020. This was really during the height of COVID, and the charge is for to be advisory to the health officer, the Shawnee County Health Department, and the Board of Health on public health issues. And yes, 2020, COVID was certainly the main focus at that time, but it's really been the intent that this group would continue to meet and advise on just general matters concerning public health in the community. As you recall, there are 5 members on the board. These are representatives from Stormont Vale, KU St. Francis, Vallejo, Grace Med, and community physicians. And there's been some recent changes, and so right now we're continuing to work with these groups in finding who their representative is going to be and continuing to work with them. We get updates from these groups. We also get updates from the Shawnee County Health Department, and that makes up a big portion of our meetings. At our most recent meeting, one of the questions that we asked the group was to think about who else needs to be coming to the meetings, who can help give us input and information. And so, community groups, school representatives, faith-based representatives, et cetera. So that was one of the tasks that we asked the group was to consider is who needs to be at these meetings, because they are open meetings too. In addition, we asked the group what are some of the future health issues that we may be dealing with as a community. And one of the things I think that everybody agreed upon was how important needs assessment was, and I think we'll probably hear a little more maybe about that when I'm done. And so everybody agrees with that. The 2 questions that we asked was those things. And so our next meeting is scheduled for December 1st. We're going to, at that point, review updates from the groups, hear what's going on. While we also are going to be looking at these long-term health issues, there's going to be acute health issues right now. We have a lot of respiratory viruses right now that are causing problems in hospitals with surge issues, et cetera. So we'll be hearing from them on that. We're going to certainly discuss the questions I asked them. Who else needs to be at these meetings? And also just what other areas and how can we help the health department and how we can help the Board of Health and give them advice on some of these issues. Any questions that anybody has?
Any questions?
I don't think so.
No?
But I appreciate you continuing to reach out to the rest of the, or including more people from the community.
You bet.
Get as many voices as possible for this.
Yeah, we only have 5 right now, but I think that was certainly the goal of this group, and we certainly want to continue to do that. The more input we get, the better we're going to be.
I agree. Thank you, Dr.
All right, thank you.
Appreciate it. Thank you. Throw it back to Craig.
Sorry, guys. Try not to be as long-winded either this time. So, okay. So this is an exciting topic for me. I love coming up and talking about community health improvement planning. I know Jim's had to sit through this before in a Board of Health meeting, so has Commissioner Cook. Commissioner Mays, I don't know if you've had the pleasure yet. So this is going to be great for you. I know we got
I'm excited.
I know we did talk a little bit about community health improvement planning when you came to the health department, kind of for that little orientation, introduction to our programs and services. So what I'm going to do today is talk. I'm going to start with really what is a CHIP. It's just going to be a reintroduction. Talk about the purpose of it. We'll go through kind of the steering committee and the things of that sort. Talk about the last needs assessment that Dr. Cooley touched on a little bit, and then where we're at. All right, and then I'll turn it over to Brett Martin, and he'll kind of talk to you about that right now, where we're at and where we're going to, and kind of some next steps that are coming up. So what is a CHIP? Well, in a sense, it's a long-range systematic effort to address public health issues. So think about this in our sense as our Momentum 2027, right? For how we look at driving priorities in our community to engage a diverse set of stakeholders to make impacts on public health outcomes and health behaviors in our community. So we do a needs assessment that kind of gathers that data, looks at what those issues are. We do a lot of stakeholder engagement to figure out what those issues are to ensure that then we're creating actionable interventions. So if you look at this whole process here, this 8-step process, right now what we're on is step 7. We're finalizing and getting ready to present the Community Health Improvement Plan. Our goal is to have this Community Health Improvement Plan done in its entirety. It's almost there. It's very, very close. We were really pushing for today, but we want to make sure it is perfect to the T. So we're right there, and we're getting ready to finish that process, and then hopefully we'll have an opportunity to then present you a nice full copy of that Community Health Improvement Plan very soon. So the purpose, I kind of touched on that a little bit already, but it is really to help us as a community as a whole. Not just the health department, not just Heartland Healthy Neighborhoods as our grassroots health coalition, not just as Stormont Vale, KU St. Francis, but as a community to really come together to create a collective impact, to look at what are the issues that are affecting our population at that root cause issues, okay? And so what we want to do is we do a gap analysis, we do a needs assessment, we get qualitative, quantitative feedback, and to us, sometimes the most important is that qualitative feedback, what we're getting directly from the people who are dealing with these issues day in and day out. And from that, we overlay that information then with the quantitative, the data that we receive through things like our behavior risk factor surveillance system, through different surveys that we do, through Kansas Health Matters, community action surveys, and look at all of that together, all right, and then look at, okay, these are the top issues in our community, and we'll talk about those 4 priority issues here in just a section. But the CHIP itself is a guiding document. It is our plan. It is what helps us pull together smart objectives with measurable outcomes, and then really actionable interventions that will have us collaborating with a multitude of community partners from a diverse set of diverse sectors in our community. So what are those sectors? So you can't do it in a silo. That's the biggest thing. You know, we can't do it as just a health department. We can't do it as just those that are working specifically on health day in and day out. And you've heard me talk before about that no matter what sector you work in, there are things that you do, whether it's in your organization or whatever that directly impact the health of your employees, your families, those around you, and those that you are involved with in the community. And so our goal here as a steering committee and as a group is to really look at all of those sectors. So we get input from the health sector, obviously, it's a health plan, but both physical and mental, right? So we want to engage our behavioral health centers, specifically Vallejo Family Services Guidance Center that are addressing the adult population and the youth population. Our health systems are a big role of this because we can dive into the patient data that they're seeing that are coming into their emergency departments, coming into their urgent care clinics, and see what are the things, the ailments and things that they're seeing day in and day out that their providers are actually dealing with. Government entities, yourselves, City Council, the Board of Health is pivotal on us at looking at adopting appropriate policies, systems, environmental changes that will make sustainable changes for years to come and help our population grow and thrive. Education. We can't do much with it if we're not engaging the schools, right? That's our future for our community. We want to engage those students and provide opportunities for healthy behaviors and quality health outcomes to ensure that our students are living bright, vibrant lives and that they want to stay here, right? We want to build our community and we want to maintain a positive, vibrant community that our kids want to stay here once they graduate. And I think that's a big thing. And I think that's a guiding thing, principle for a lot of the work that we do here that you see for the people that are in this room. Business sector. Again, we can't do this without our partners in the business sector. Even the work that they do, if they don't realize it right now, we thrive for those opportunities to meet with our business partners in our community to talk about what impact they have and what they do in their own organizations that impacts the health of their employees, that in turn impacts their employees' families. We want to work on reducing absenteeism, right? We want to increase productivity in the workplace. And so looking at policies and things of that sort that will increase the time that their staff is at their workplace doing quality work and less time off-site and not having to figure out ways to pick up that deficit. Housing, again, one thing we continue to hear about, there's a great housing study that was done in the city of Topeka. So we try to actively engage the Topeka Housing Authority, our property owners that own multi-unit housing throughout our community to look at ways to make sure that, okay, if you're looking at rent 1 month, right, or providing a healthy meal for your family, can we look at alternatives and ways to increase the opportunities that people can get that healthy meal for their entire family because they are not sitting there worrying about whether they have a roof over their head or if they can pay their bills to maintain that. And then obviously not-for-profits. I mean, they're in this to improve our community. And so it's really important for us to engage the not-for-profit community here. And because they're the content experts a lot of times in the different fields. When we identify a gap, we want to engage stakeholders that are already working in this field because we don't want to recreate the wheel. We want to figure out if we can leverage the work that they're doing to increase not only their capacity, but their ability to impact positive change in our community. So those are the big 6 sectors. I know there's some that I've left off there, but the point of this slide here is to truly show that we look at a diverse collection of stakeholders from across the entire community. And I would argue with anybody if what they do doesn't impact the health of the community. And so if someone feels like that, if anybody's watching this right now, call me. And I'd love to have that conversation with them. So what is our steering committee? So we have 4 core partners right now that are engaged in the work that is done around guiding the principles and the outputs that we do through our needs assessment and our improvement plan. So it's Heartland Healthy Neighborhoods. Like I mentioned, that's our grassroots health coalition, Stormont Vale Health, Shawnee County Health Department, and the United Way of Greater Topeka. And so I want to quickly on this slide introduce a few people who are here today in the audience that are representing those. So Heartland Healthy Neighborhoods, there's 3 of us that are on the leadership team. So we have Brett Martin, who you'll hear from in a second. He is our current board chair. Myself is our past chair, and then Eve Kendall is one of our leadership members as well. With Stormont Vale Health, we have Savannah Gomer there in the back. She is a representative from the Community Engagement Division within Stormont Vale Health. That is looking at one of the new pillars that Stormont Vale adopted, I think 3 years ago, correct, with the last iteration of the Need to Spend and the CHIP, to engage more thoroughly and really targeted interactions with the community around community engagement. The Shawnee County Health Department, well, you're listening to me. Obviously, I'm engaged in this process, so as our Division Manager for Community Health Outreach and Planning. And then Brittany Blattner is our epidemiologist and serves on that. Obviously, we need someone who really can analyze the data better than a lot of the other folks at the table. And so Brittany does a great job of that. And then United Way of Greater Topeka. So Brett Martin here is the Vice President for Community Impact. Again, you're hearing a lot of that community piece. And those are the people that we want at the table to really help us drive this change in our community. Okay. The other piece that I want to say on the steering committee is we're still constantly looking at other organizations and individuals to engage in this work. So the health department is engaged in this work because of part of our accreditation, right? We're required to do a community health needs assessment and a community health improvement plan every 5 years, all right? Stormont Vale Health, as a not-for-profit hospital and health system, is required to do one for their IRS regulations every 3 years, okay? So the timelines are different, but it doesn't make sense for us as a health department to do one standalone health improvement plan and a needs assessment. So this is where that collaboration was really built together to engage in this collectively. Again, to make that collective impact and build upon each other's capacity to make that positive change and do a full analysis of our community. So looking at ways to expand that, we have some partners who were at the table before that we're trying to re-engage and bring back to the table. And then as we look at those priority areas, again, the same thing. Who are the other partners that we could bring to the table that are those content experts and help us drive that change? So, going to go back a little bit to 2021, talk about the needs assessment, because I think this was a resounding success for us. You know, this is, you'll see here, this is kind of our third iteration of what we consider our new kind of needs assessment and CHIP priority setting. And so we did a community survey in 2021, perception survey that we made available both in English and Spanish and pushed out very heavily. I was excited to say we had 2,536 responses to that survey. That is a lot of responses to a community health survey. It blew the last community health needs assessment out of the water. So we had great engagement from the public sector, which was fantastic to see. We had a paper surveys that we were collecting that we partnered with a lot of community organizations to put out, as well as an electronic survey that we provided. We had a lot of QR codes throughout the community, surveys that were pushed out through social media, so it was great. We did 15 targeted roundtables. This was an increase from the 3 that we had done with the last iteration. So we had targeted roundtables looking at specific subpopulations in our community, different demographic groups, to make sure that we were getting the best information from those who were being impacted by health behaviors in our community. And so we had 148 attendees through those 15 roundtables that we did. And think about this, we were doing this still as COVID was still making it a little bit difficult to do a lot of this community engagement. And so we did all of these in this Zoom format, which made it a little bit difficult, right, to get some quality feedback, but there was a lot of engagement, there was a lot of conversation that was happening back and forth, and so that was a really positive experience for us. And so now we've learned that when we go to the next iteration, providing these dual hybrid models, right? So for people to be able to come into, because our goal was always go to where the people are. So we want to partner with organizations to go into their communities so that if access is an issue, we're right where they are. And so that's going to be a key thing for us, but then maintain that hybrid possibility. So if they still can't get to, say, Fellowship Highcrest, right, one of our strong partners, then we can provide a hybrid model to where someone can join online through Zoom, right, and partake in that discussion that's happening on site in that community in Highcrest. And then we had our big virtual town hall community conversation that we do annually, typically in April and or in May, that kind of coincides with the release of the county health rankings. Talk about that, talk about the needs assessment, do some prioritization exercises. And so we had 95 attendees at that last community conversation that represented 45 different organizations in our community. So what did we see from that community survey? We had, for this round, a much more even distribution of respondents across all those ages. We had increased participation from non-Caucasian groups. That was one of the things we tried really hard and diligently to work on for this iteration because we had a lot of our white Caucasian population that was responding to the survey. We did not have a lot of engagement from our Hispanic Latinx populations and our Black African American populations, but we saw those numbers increase. We still have work to do. I think that's key. I want to make sure that we mention that. It wasn't all great, but we had a bigger increase in the numbers that we saw from those demographic groups. And so we will be continuing to look at and working with those trusted agents in those community areas to figure out how we can get this survey out for the next iteration that we'll be doing in 2024. So not too far away from now. So expanding that and getting more data allowed us to also do a little bit more in expanding the community profile section of our needs assessment. So we were able to expand the demographics section, areas on economics because of those increased partnerships and collaborations and conversations that we had with our business sector. Education, again, the same thing. And then, of course, this time we expanded into a section that specifically because, well, COVID-19 exacerbated a lot of the longstanding health disparities in our community. So we wanted to tie into a section that specifically highlighted some of the issues that arose out of the COVID-19 pandemic and how that impacted. So one of the great things that we did was we got funding last year to also expand and do a full comprehensive food system analysis of Shawnee County. And a lot of that dove into the food insecurity issues that we saw in our community to drive some help with us that gave us even more information to drive into the actionable interventions that we'll kind of talk about here in a section. And one of the other things, and I want to give a major shout out to Brittany, is the work that she did on the data side to do a comprehensive analysis and comparison of our county and the numbers that we saw in our community compared to other like-size, likely demographic communities in Kansas. So we had kind of a comparison to those 4 counties. So looking at Wyandotte County, Douglas County, Leavenworth County, and Riley County. And so comparing where we were at in our community compared to those so that we can evaluate what are they doing on the positive side of things that we may be able to also do here in our community. So, updating the CHIP. I've got, I think, only 2 slides here, and then I'll turn it over to Brett, and you won't have to listen to me anymore. So, big things that we're doing here, just kind of talk a little bit about the work and the process that's happening in 2022. So, a full re-engagement of the HHN work groups, Heartland Healthy Neighborhoods, to work on these CHIP priorities coming out of the pandemic was great. That community engagement, getting people back to meeting together and talking about these issues. So holding a handful of new stakeholder meetings, evaluating the current CHIP strategies that were on our 2020 to 2022 plan, seeing what the progress was that was made. You know, for lack of a better term, we kind of lost a couple of years there with the pandemic on some of the work that we were able to do, especially in that community engagement realm, just because a lot of partners, health department included, but across the community, were dealing with the impacts of COVID-19 directly in their organizations and in the populations that they serve. So we were reassessing the landscape in Shawnee County. We held that great community conversation in May 2020. We had a CHIP prioritization exercise, breakout sessions by priority area to evaluate the goals that we currently have and where we want to get to and what some potential interventions could be that we want to build into the CHIP and really see some progress made. So action planning for that whole year has been being done by those core partners with the steering committee to make this update. We're hoping the CHIP will be completed here by 2020 or December of 2022, so real soon. We're really putting the final touches on it right now to make sure that it is one great, comprehensive, cohesive document, and it is that guiding plan towards actual health outcomes in our community. And then, of course, throughout the whole process, I mean, this is one of the big things, it's just an ongoing monitoring and analysis. New issues arise. We want this plan to be a living, breathing document. We do not want this plan to be something that's created and it just sits on a shelf. We want to create this plan that allows us to flex and pivot to new and arising issues in our community and how that impacts those 4 priority areas that Brett's going to talk about here in a little bit. And so, case in point, just this week on Monday, KDHE released their Healthy Kansas 2030 report. It's a nice 98-page document if you're so inclined to read it. I haven't made it through it all, but that is a new data source that's coming out from the state of Kansas that's looking at their goals, their priorities, and the objectives that they're looking at to try to impact health behaviors by 2030. That coincides with Healthy People 2030 on the federal level. So, a lot there, and so. Kind of what I want to talk about before I turn it over to Brett on the next slide here is where we've been and where we're going. So 2015, some of us in this room, this was our very first community health improvement plan that we ever did. All right, we did this on a 5-year cycle. We learned a lot from this iteration, the good and the bad, and evolved that into then our next one. This was a great CHIP still. Learned a lot from what we were doing there, the good and the bad, and how to evaluate. No plan looks the same. With this one, we did a lot of opportunities, what we called opportunities for community involvement. There was no real true ownership, but we had a lot of positive momentum through Heartland Healthy Neighborhoods on driving positive change. But we had no ownership and really no way to track that progress and evaluate our successes. So we built a lot of that in on this 2022 plan. And you'll see a lot more of that in the next one. And so with that, I'm going to turn it over to Brett Martin. He's going to kind of dive into where we're at right now and where we're going. So,
Great, thanks for the opportunity to share just a little bit. Thanks for the background, Craig, giving us a sense of where we are now. So when we talk about the new CHIP for 23 to 25, what's that look like? What are the priority areas? Based on the data that we collected from the community, based on the feedback that we had, based on that quantitative and qualitative data that Craig alluded to, still 4 priority areas, much the same in terms of what we had prior. So behavioral health, access to food, substance use, and health equity will be the 4 priority areas within which we've developed strategies to improve health over this next cycle. So to give you a sense of what that looks like, we'll take a look at each of these areas and look specifically at what some of these interventions might be. Obviously, behavioral health, significant issue in our community regardless of where you live. These are issues that aren't limited by zip code. They're not limited by school district. They're not limited by neighborhood. They're not limited by gender or race or ethnicity. So when we look at the interventions here, in particular for behavioral health, we look at our local suicide prevention coalition and also the statewide suicide prevention plan, looking to implement and expand both current strategies within both of those plans so that we have alignment at the local level but also at the state level, as well as looking at program interventions to raise awareness and to provide training to individuals across the community in order to prevent suicide among the citizens of Shawnee County. In addition to that, as you know, oftentimes we're able to achieve greater systems change if we have agreements and relationships at high levels. And so we'll be looking at increasing MOUs across organizations and amongst agencies in order to better coordinate care so that individuals are not running into systems barriers as they are moving through the various care systems that folks are looking at. And again, we're looking at that ease of access in order to be able to facilitate not only the partnerships at the top, but also then ultimately create better outcomes for those who are navigating those systems. Access to food, significant issue in our community, as we have talked about the prevalence of food deserts that really begin in the center of our city and extend to particularly to the eastern end, but also then looking in county areas and different communities that have lost grocery stores, for example. So we think about Auburn, and then we think about the opposite end, even up into Oakland, the loss of grocery stores just in the last couple of years. So access to food is significant issue. So what are we doing there? Really, the closure of the Dillons and the Huntoon and Lane corridor in the center of the city precipitated the work that's now being done by the Shawnee County Farm and Food Advisory Council. As we took a look at the closure of that grocery store, we recognized that while it would be important to recruit grocery stores within certain areas in the community, we also knew that we needed a larger body taking a look at the food system and seeing how it is that we could potentially prevent that in the future. And so we'll be working again through that group to look at policy systems and environmental changes in order to be able to strengthen the food system across the county. Additionally, during COVID, we recognized that we had a gap in information related to food access in our community. And so we leaned on our partners at K-State Research and Extension, as well as partners with Shawnee County to develop a food distribution map that's updated in real time that provide folks with opportunities to be able to see where it is that food is available throughout the community in order to be able to access that. We had a number of food pantries and we had a number of places where people would access food, but no one knew about them. And so we were able to map that and share that across a number of community partners. That's another intervention example in the area of food that we will be driving through the 2023-2025 cycle. Substance use, obviously a significant issue in our community. It seems to be folks younger and younger. When we first started our substance use work at United Way of Greater Topeka years ago, we had a task force that was focused on this, and we were looking at youth smoking at the time. This is 2008, 2009, 2010, and that group developed a strategic plan And within just a couple of years, they met their goal. So they disbanded. What no one was thinking about in 2010, 2011 was e-cigarettes and vaping. We certainly celebrated the significant drop in youth smoking at that time, and so that group disbanded, but nobody kind of imagined where we would be today. So lots of different issues related to substance use in our community, and so a couple of interventions that we're looking at in particular there. As Craig mentioned, housing and looking at those who have multi-unit housing across the community, in particular Topeka Housing Authority, such a great partner across the community, looking at working with them to implement tobacco cessation, both tobacco-free policies and cessation programs for residents in those areas. Additionally, working with our Substance Misuse Task Force, a new partner within Heartland Healthy Neighborhoods, to increase the number of naloxone trainings in the community for folks to be able to intervene, in particular in instances of narcotic or opioid overdoses. And so looking at that as well. We're very excited about the group and the work that they're doing. Lots of partnership with the Shawnee County Health Department and with our local hospitals, and so we're looking forward to seeing those interventions create some results over the next 2 years. Finally, looking at health equity. Health equity is this area that's rather broad for us when we take a look at those things that individuals and families need in order to be able to thrive, in order to be able to live healthy lives. There are 3 areas in particular: maternal, infant, and child health, sexually transmitted infections, and obesity, the 3 areas within our health equity work. And so just an example of 3 interventions examples here. We often talk about, in terms of health equity, we talk about access and trying to create better pathways for individuals to remove those barriers so that they can achieve the health outcomes that they hope for themselves or for their families. So looking at increasing access to those services across the board, not just what we think about in terms of traditional physical health care, but also dental, mental, and prenatal education for those individuals. We take a look at sexually transmitted infections. It's often the thing we don't talk about in our community, but we take a look at the data and we know that it's a significant issue among the population at large, but when we disaggregate that data, particularly related to age and race and ethnicity, we know that we have disproportionate inequities across the community. And so we have established a cross-sector sexual health collaborative that will be bringing partners together to take a look at the work that they're doing individually and to then maximize that individual work collectively in order to be able to create that system. Again, talked about systems a lot here, but that systems alignment so that individuals who are receiving care from different organizations don't have the barriers that they currently have. And so we'll be taking a look at that and be taking a look at specific populations of focus who are disproportionately affected by sexually transmitted infections. Finally, obesity. One of the things we learned in this CHIP is that we don't have a local expert on obesity. We have experts in the area of substance use and behavioral health and maternal and child health. We don't have a recognized expert in this area. And so I think that's a challenge for us through the 2023-2025 cycle to continue our conversations. But in the meantime, we're looking at the experts that we do have. And so we look at things like built environment. So we'll be updating the Trails Master Plan for Topeka and Shawnee County in partnership with Pathways to a Healthy Kansas, which is a grant that we currently have through Blue Cross Blue Shield of Kansas, which is making a lot of Heartland Healthy Neighborhoods work possible, and we're grateful for that partnership. In addition to Heartland Healthy Neighborhoods in Shawnee County Parks and Recreation, and we're grateful for the relationship we have there, and the update of that plan, which hasn't been done, I believe, in nearly 20 years. I think will be able to give us that macro level that will then allow for potential grant opportunities and expansion opportunities for folks within the community. So when we take a look at our work groups and we take a look at what we look like, we are very excited that we have a director. And I mentioned the Pathways to a Healthy Kansas grant. That has made possible the hiring of a director for the first time since the development of Heartland Healthy Neighborhoods in 2008. Sarah Carnes, she was unfortunately unable to be here today, but she is both the Pathways Coordinator and the Director of Heartland Healthy Neighborhoods. We're very excited to have her on. In addition, we do have, as Craig mentioned, our CHIP and our CHNH Steering Committee, and then our larger leadership that drives the work. Obviously, I serve as chair, Craig as past chair, and then we have our various work groups, and you can take a look at those individuals who are experts within certain areas who are driving that work. And we're certainly grateful for all of those folks who really carry the burden of implementing the CHIP. And that's what they'll be doing over the next 2 years, is driving these intervention strategies and then reporting to us quarterly on what that looks like. As Craig mentioned, you saw with the last CHIP that the last CHIP began January of 2020. And you know, obviously, what happened in January, February, and March of 2020. So we have this nice, shiny new document that we had developed in the fall and winter, and then had a significant disruption. And so as a result, we have been able to reconvene folks, and we've been able to do that a couple of times, but wanted to provide an opportunity for the larger community to participate and to give feedback to us as we move ahead as Heartland Healthy Neighborhoods. And so just wanted to point out Thursday, December 15th from 9 to 1 at the Topeka and Shawnee County Public Library, an annual action summit. At that annual action summit, we will hope to reignite the work of Heartland Healthy Neighborhoods and the coalition of partners that make that up by introducing the new CHIP, by taking a look at our pathways opportunities and the funding chances that we have through Blue Cross Blue Shield of Kansas, in addition to taking a look at those other areas that we might engage stakeholders across the community over the next 2 years as we hope to drive better health outcomes for the community. So that's just a snapshot of what this 2023 to 2025 CHIP looks like. Again, my contact information here. I serve as the chair, Sarah is the director, and Craig as past chair. Wonder if you might have any questions for me or for Craig today.
Brent, any questions?
So we've been talking about the Community Health Improvement Plan, or CHIP, but as commissioners, we are often looking at the county health rankings. The health rankings, and I've been pulling up their health rankings because I just couldn't remember off the top of our head how the 2022 health rankings came out. Two different things we're looking at, though, your health improvement plan and your health rankings, but how are we looking to address some of the deficiencies we have in the health rankings to the improvement plan?
Yeah, absolutely. Do you want to take it?
Yeah,
sure.
So the health rankings comes out every year, and
Right.
typically comes out March.
Shawnee County's at
and/or
56.
April. Yes, there we go. So what you'll see in the needs assessment is we take that into account. In the needs assessment, we take the data that's received in the county health rankings and incorporate that into the needs assessment because it gives us a good snapshot at where we're at. And so one of the great things, about the health rankings is they do that on a yearly basis. And they take into account a lot of the data that we're looking at already for the needs assessment, but then it also gives us an opportunity yearly. One of the great things about that community conversation that we do around that same time is to do a re-engagement and to re-engage and dive deeper into some of those areas that we may rank poorly compared to other communities here in Kansas, but also to look at our successes. And so that what we do with the health rankings specifically is, because and data lags are a little bit, so what we're looking at when we see the rankings for, say, 2022, right, might be data that we're receiving from 2018, 2019. Mm-hmm. So that's why we use the health rankings primarily as an educational opportunity. That re-engagement to talk about where we were at, where we are now, what we're doing to address some of those issues, and where we hope to get to be. And so that's why the Community Health Improvement Plan is really worked on and developed off of that needs assessment, off of the health rankings, so that we're driving those interventions. So what you should see is those as a cohesive piece. You should see items in the Community Health Improvement Plan that are directly applied to what we notice in the health rankings. And so there's things in there that specifically talk about poor mental health days, right? There's things in there that talk about the built environment and access to recreational opportunities. There's things in there that talk about sexually transmitted infections. And so where you see poor rankings, most likely on the county health rankings, you should see interventions that are then developed in the CHIP that are trying to work to address those issues moving forward. And so sometimes it just takes some time to move the needle, right? Rome wasn't built into it in a day. And so this is making sure that we bring all of the correct stakeholders to the table, making sure that we see what each partner is doing in their areas, and then we figure out how we can leverage each other, build upon that capacity to make that positive change moving forward. Does that answer your question?
It does. And I mean, and you're right, there is a data lag in the health rankings, that they're looking at data that was collected in 2018, 2019, 2020, but reported in 2022 because it took that much time to digest it and be able to process it.
Right.
And so oftentimes we're responding to something that may or may not be the current condition.
And I'd say, you know, one thing additionally about the county health rankings, and I know I've shared this before, you know, sometimes the ranking, the actual physical number, doesn't mean a whole lot, right? Of course, it's great for media to pick up on and have discussion point, but, you know, what you could see and how you move could be based on positive changes you've made in your community or negative things that have happened in other communities. And so we always want to take that and peel it away like it's an onion and look at all of the different layers. And that's why we use the county health rankings primarily as that discussion point, that touch point to make sure that we can re-engage with community partners across the sectors.
Thank you.
I would say the other thing related to that is when you look at something like premature death, for example, within the county health ranking, something that people often would look at right away, you see the interventions that we have within the behavioral health, in particular with the alignment of both the local suicide coalition and also the state prevention group, and being able to kind of drive those types of things. So those are ways in which that data is used alongside stakeholder data and other quantitative data to be able to do that. Interestingly enough, the things that we often see in the health rankings are those same things that people talk about in stakeholders in neighborhoods across our community. So I think it's important because people recognize those, and so there aren't things that are coming up that people at least aren't concerned about at some level in our community, and I think that's important. I think it's important for it to come both from the data at the top, but also from the community, kind of from the ground up.
Thank you.
Any other questions?
No.
All right. Next item on the agenda is public comment. Is there anyone wishing to speak? All right. Teresa, did you want to wrap it up, or?
Well, again, this was just an opportunity for us to reflect on the work that we've done. We look forward to bringing these meetings back. The plan moving forward, we've kind of discussed internally and with some community partners, is that we will plan to do both a spring and a fall meeting. So moving forward, two meetings a year. And we look forward, we hope that today's meeting was informational. Hopefully you learned something new, as did the public. And if there's ever any topic specifically that you or the public would like to have addressed at these meetings, we welcome that input. So thank you for today's Board of Health meeting.
All right, thank you. All right, we're adjourned.